So I'm Michelle Kirkbride. I'm one of the community development coordinators, so managers over here at the NorWest Co-op Community Health Center in Winnipeg, Manitoba. And I've been working with several groups on several health promotion initiatives that kind of involve mixing primary care with social services and community development, including the Hands Kai project. But we do a lot of work here with our racialized communities, and that's what we're going to focus on today. And I'm going to turn over to Caprice to introduce herself.
Hi, I'm Caprice Kaler. I'm the trauma team lead here and the community facilitator. I've been here at NorWest for about 19 years, like kind of with Michelle. I'm going to talk a little bit about my work throughout the presentation. So I guess just one thing, we have a trauma team here at NorWest, a trauma response team. But during COVID, I was pulled into the Winnipeg Regional Health Authority to provide trauma support and self-care supports to healthcare providers that were working through COVID. So yeah, it changed a little bit. Now I'm back here.
Okay, so I'm going to share our screen. So with that, Caprice is going to lead us off with a land acknowledgement.
Yes, I'll explain this a little bit later on down the road too, but I just wanted to acknowledge that we're here today in Winnipeg. We're in Treaty 1 land, Treaty 1 territory. It's the traditional lands of the Anishinaabe, the Cree, the Ojibwe, Dakota, and Dene peoples, and the homeland of the Métis Nation. And we just want to respect and acknowledge the harms and mistakes of the past and what is presently continuing Indigenous folks on our land. And we dedicate ourselves to collaborating in partnership with the Indigenous, Métis, and Inuit people in spirit of reconciliation.
Thanks, everyone. So as Caprice mentioned, we normally start a land acknowledgement. She'll explain more about why we do them later on. But as we know, we're from the NorWest Co-op Community Health Center. We're a health and social service agency in Winnipeg, Manitoba, providing primary care services, counseling, community development, and health promotion services. So although we mainly serve the Inkster community, we are also very population specific when it comes to our programs and services. And our geographic community up here in Inkster is very diverse. So our demographics include significant populations of racialized communities, including Indigenous folks, South Asian, North African, Syrian, and Filipino populations, which means our approach to healthcare has to fit some of those models so that we can actually make sure that everybody has positive health outcomes. We also have fairly high incidences of poverty, low housing for families and individuals, and a significant prevalence of diabetes, hypertension, and asthma, anxiety, depression, and substance misuse, which can culminate in some very complex health issues. And again, as we're hearing around the table, we're facing a lot of those issues here in Canada as well. Lack of ability to attract GPs, nurse practitioners, and even nurses. So historically, doing healthcare work in Canada has been a bit of a challenge when we're working with racialized populations such as the Indigenous population. There's been a lot of mistrust between the Indigenous population and what we would call mainstream colonial systems. So our healthcare system in Canada is very much based on a Western, somewhat colonial model, and that can create stress between those two communities. Canada has over 50 First Nations and 50 Indigenous languages. I should note, Canada has 2 official languages, both English and French, and that we are now working with the impact of residential schools and cultural eradication that have had a huge impact on our Indigenous community. So I'm not sure if everybody around the table, Australia, I'm sure probably very aware of it, but everyone around the table knows the impact of the residential schools. So starting in the late 1800s up until 1996, First Nations children were taken from their homes with no contact to their families, taken to residential schools that were run by mostly different church organizations and government, and needed to learn to speak English and essentially adopt a more Western way of being, had to, in many cases, have their braids cut off. They were not allowed to speak their language, practice neither regular cultural activities. And so it was essentially a cultural eradication that has caused long-term harm on that community and in its connections with other communities. There's a lot of mistrust. And Manitoba, where we are located, has the largest prevalence of Indigenous populations, including 130,000 people identifying as Indigenous, and over 60% of them are living on reserves. So that's land designated, usually poor land, designated for Indigenous governance, where they run their own, they have their own governance. So focus as we move forward is now on reconciliation. And though today we're mostly focusing on the Indigenous population, this does talk about some of our other racialized communities here as well. Like I said, we do have high North African and some South Asian country populations that are facing similar issues. So these are some pictures you can see of what our community actually looks like. The middle picture is actually one of our community powwows that we sponsored, where we had a powwow club and beading club, and they were able to make their own regalia, which was a really big piece. For a long time that was banned. You can see one of our Hans Kai classes up in the one corner, and the other class, this is September 30th, which is the Day for Truth and Reconciliation. And we were doing a kind of event.
It was a bit of a sharing. This was a sharing circle outside.
Yeah. And you can see that orange shirts we have Orange Shirt Day, which is to recognize the harms of residential schools. Also missing and murdered Indigenous women. And this was also some drumming happening here. Okay. So what we've done as an organization, and Caprice is going to take on the first part of this.
Yeah, so in Canada, in the last maybe about 10 years, I think our government has focused on a lot more about truth and reconciliation. So the truth is what actually happened. There's been lots of focus groups and stories from the people, from firsthand, people living in residential schools and their children. So hearing exactly how they were treated and what exactly happened, and then how the reconciliation. So how can we as a country move forward and support the wrongs that we've done, I guess, that our government has done. So there's been a report written up, and there's how many? There's actions. There's call to actions. So one of the call to actions is doing a land acknowledgement, and that is why I did that today, to acknowledge that this is not our land, it is the Indigenous people's land, and we're now kind of admitting it openly, which is a start. So we have a Truth and Reconciliation committee here. So it is run with the Indigenous folks at NorWest, the staff that we have, and anyone can join it. So it's learning about those call to actions. What can we do as a community, as a health organization, for staff? How can staff learn more about what we can do with our community and that sort of thing? Another thing that we've done is we have employed an elder and our knowledge keeper. And I don't know, I'll explain elders a little bit down the road too. I'll explain actually those two down the road. The creation of a round room. So in the Indigenous culture, as you know, teepees are that's what they lived in, and we still do a lot of sweats and traditional and cultural practices in teepees. But in a health center, a lot of our health centers now in Manitoba are built with round rooms in them, so we can smudge. I'll explain a little bit about smudging later. So people can smudge and get back to kind of their roots and their practices. So it's not always coming into a kind of a clinical setting, but more of a traditional setting for them, and to help with safety and with their culture, which I'll also get into a little bit later. And then working with community leaders. So, our community knows best. The Indigenous folks in Manitoba know what they need, they know what they want, they know what they're missing. So we really try to work with, some of the people that have come down from reserves, the reservations or reserves, and, ask them really what do they want in the community, or what are they hearing from the community. And Michelle can tell you a little bit more about the vaccine project.
So yeah, the vaccine project, unfortunately, we're all familiar with the impact that COVID had on all of our communities across the world. But when the vaccines were announced in late 2020, we live in a community that has historically poor vaccine uptake. And part of that is access, part of that is a mistrust of healthcare. And part of that is also that we don't really take the time to talk to the communities that aren't getting vaccinated to find out what those barriers may be. So when those were announced, we actually worked here, all of it, at least initially, was done virtually. We had essentially town halls with identified community leaders from all of the populations that we spoke about. So, and we wanted to find out, what are your questions about the vaccine? What would make you likely to get the vaccine? What would make you not likely? And how would you want to make sure that accurate information about the vaccine is getting out into your community and the reasons why you would be encouraging people to get vaccinated? And it was usually myself or one of the other community development team members, along with a nurse, going out to these events. And then we would have connections in the community with those local leaders. And with those local leaders, that also included youth. We had separate ones of town halls for youth. They created their own information. We translated all that information into 17 different languages, including Cree, and there was Cree and Ojibwe, I believe, yeah. And we also then worked with those leaders to go door to door in some of the communities to talk about the vaccine. And we noted that when it was community leaders giving that information versus more mainstream professionals, our uptake significantly improved. And so we actually had a significant improvement in vaccine uptake through giving a voice and removing barriers and hearing from the community itself. I mean, it was a very intensive project and a lot of work, but the results, we believe, were actually quite powerful.
Yeah, and community advisory and leadership. So in our community, we have a lot of us work, we do a lot of outreach, and we have resource centers in housing developments. And in those housing developments, we have advisory, community advisory meetings quite often, where the community comes together in one of the resource centers that we have, and they tell us what they want, like, how can we provide better services for you? So one of the things they told us is that it's very difficult to come to our main office, like our main clinic, where Michelle and I are sitting now. Transportation is very expensive. It's actually super cold here right now. It's like minus 40 degrees Celsius. So yeah, so it's super cold, and it takes money. So for them to travel here to the clinic, so we have space in the community. So we've been getting our nurse practitioners and our physicians to actually go into the community and meet with our community, and it's been working really, really well. And they're creating such a better relationship with the folks too, and like hearing a lot of their real traumatic stories behind their physical ailments as well. And in those advisory meetings, there's community leaders who come out and tell us what they want. The other day they told us they want a gardening committee because they want to plant their traditional medicines and be able to pick those through the summer. So we try to really hear firsthand from the community what they want.
Yeah. And that would be exactly what Caprice was talking about, incorporating cultural events or practices into the organization. So like, for instance, right now we're coming up to Ramadan. So we often have community lunches. So on those days, we'll also have takeouts available for anyone who's needing to break a fast. And we know that it's traditionally dates and nuts and water to break a fast. So those will be available at lunches or at our markets. We also have pop-up fruit and veggie markets. We're also incorporating things like being able to have prayer rugs for people to come in and pray during that time. Being able to, Caprice will talk about it later, but being able to smudge before starting a session, or offering cedar tea instead of coffee, which is much more traditional in the prairie Indigenous populations. So those are just like some small examples of some things that create a lot of trust within those communities themselves, so that you are seen as an organization that people are comfortable going to, knowing that their cultural expectations will be respected. And with that, sorry for the typo there, I don't know what happened. We've actually changed some of our hiring practices. So we're lucky enough here to employ an elder, and I've been blessed enough to be able to sit with the elder during a hiring practice, and she was able to give me feedback on what I could do differently to work with different racial populations to really get their story out. So she said, for instance, with the Indigenous community, straightforward questions and answers that we usually ask, we don't usually get a really good sense of what their skill set is. And so I heard Paul earlier reference storytelling, and so we've moved interviewing to more of a storytelling practice, and it's been very fascinating at the differences I can find with skill sets when we've moved it that way. So that's been very, very helpful. And I think the biggest thing for us is ensuring organizational processes for elevating diverse voices. So normally I would have actually had our knowledge keeper be here today to do this instead of me, but unfortunately our knowledge keeper has been ill. But that is part of what we're talking about. So it's not enough just to hire a diverse workforce that looks like the community you're serving, but how do you elevate that so that people coming into the organization feel they have a voice and can speak on behalf of changing things. So the TRC committee is one option, but even within our communications committees, within our committees of practice, those populations, those staff are represented, and we actually have a process for even taking that out to the community. So we call them community health ambassadors, which will be in any of our cultural communities. How do we give people the information that they want and listen to them to change our processes as an organization? So I think it's really about making sure that, especially for me as a white person around the table, that I'm not the first one speaking, and that I'm actually asking for ideas and listening to those ideas and seeing how they can work. Anything you want to add with that? Okay. So, again, some pictures. That's one of the fruits and veggie markets I was speaking about, led by community volunteers. And again, some of our kiddos after powwow. Okay, so one of the ways that we're actually doing this has been very exciting. During the pandemic, we actually started what we called a wraparound project. And the wraparound model of care is actually, I think, an international model. But what we did is, instead of taking a traditional, like you're going to come in and you're going to see your physician, you're going to see your counselor, and we're going to fix what's going on with your diabetes or fix what's going on with your anxiety, we switched to a bit of a wraparound model. And now we're trying to look at that model beyond its pilot, and how do we integrate those core philosophies into all the way we work. So wraparound really means, initially, someone would, and I can take you through the little graphic here, someone would talk, at this case, we would name the staff, one of our staff, about whether or not the wraparound process is right for them. So we would gather information about them through our referral form, and then they would take them through what we call a strengths, needs, culture activity. Similar, you'll see it in the next slide, but similar to what we have here. Where they can look at what are their strengths, where are some of their challenges, and what do they want to achieve. So, for instance, if, I might worry about someone not managing their diabetes, but they're actually more worried of the fact that they don't have a home to live in, that home might be the first goal, which will then maybe enable them to stabilize their diabetes a little bit down the road, right? So it's really hard when we're picking what they need to work on versus what they're picking. And so after that, they get to pick a team of anybody. It could be health professionals, it can be family members, friends, whomever it might be, that's going to help them meet those goals. And they have a team meeting, which is facilitated by us. And we talk about what their goals are and who's going to help with each task. And then they have monthly meetings after that. But in between them, they have a facilitator check in to see how they're doing. They can meet with a clinician to talk about any issues that might be coming up. And we actually help them reach their goals. It's usually about an 18-month to 3-year process. So it's very intensive. It doesn't necessarily work for everyone. But then we actually help them reach their goals. So this is one of the sheets we use. One day I want to, and it seems fairly straightforward, but this is, like we said, the strengths, needs, culture. So they do this strengths, needs, culture discovery. And it really reflects to them the way, sorry, I'll just mute that. The way that they see themselves And what's been very interesting about that is that when we've done this with people who maybe struggled in a more mainstream healthcare setting, it's been really interesting when we take this strengths-based culture discovery back. Sorry, I'm just gonna try and mute that as much as I can. The strengths-based culture discovery back. Sorry, I'll just wait till it's. Basic, I've never seen myself that way before. I never realized I had so many strengths and I didn't think I could do this. So it's a really nice way for them to reflect on all of the amazing things that they actually do have going on that enable them to be able to be successful at achieving their goals. And so this is kind of what WRAP is. So it's a participant-led program. They're the boss. They're in charge of their plan that meets their needs and dreams, and that they will be respected, heard, and understood. So they honor each person who is a part of the WRAP process and their choices and goals. And that part is really important because, like I said, traditionally in our healthcare system, we're telling people what they need to work on, and here they get to choose it. And so we always have a rule: no shame, no blame. So you focus on today, you don't worry about what happened in the past. A lot of our people who came into WRAP during the pandemic, their goal was to stay sober. Some of them did, some of them slipped up, and we were like, well, there's no shame, no blame, you start again. And Russell and Melina have said that we could share theirs. Right now, Russell and Melina are in WRAP, and one of their goals is to go to the Aboriginal Center to sign up for classes to improve their education. So you can see there that they had help getting bus tickets to do that they helped getting arranging childcare, and they looked at the strengths they had, which is what that strengths-based culture does, in order to be able to achieve that goal. So they both have motivation and drive. They can advocate for themselves. They have good relationships at the school. They volunteer with us. They're very talented in beadwork. They've persevered despite many difficulties. They have great knowledge of their own community. So quite a number of them, right? So that actually helps people coming from that strength-based model. And so I'll just end with that quickly. What we're doing is WRAP really looks at, like, how do we look at what the client or patient or the participant want out of their healthcare, and then how can we support them in getting those goals met? So we're trying to look at more of an integrated model of care and using those WRAP principles when we're meeting people, so that we can actually meet the health goals that they have set up for themselves. And usually that results in far better health outcomes as the end result. And just here you can see this is one of our vaccine clinics. So in order to make it like a safe space for our Indigenous community, we actually brought drummers, which is one of the things that we had heard from our community. And so, as I mentioned, WRAP we use as an individual process, but we also use it in community group settings. So our community advisories use a WRAP process where we identify what is it we want to achieve, what are our strengths, what are our challenges, what are the things we want to work on right now, and what are we going to do in the next 3 months. So we use that throughout the organization, and I'm really excited to see where we're going to be in 5 years when we've integrated a lot of those systems and values into our mainstream environment. So I'm going to turn it over to Caprice now, and she's going to kind of finish with the next little bit.
Yeah, so I know we have a lot to say because we do a lot of different things here at NorWest. So the next little bit is just, we're going to show you what's been working for us. I mean, there's lots that we're still learning about, but what's been working. So incorporating cultural practices into our workloads. So our knowledge keeper, we always try to meet the person where they're at. So we're the participant where they're at that day. So we do have a lot of people that are coming in and using drugs or alcohol. And again, there's no shame and no blame. So, but if they're telling us that they want to do something about that, we don't generally bring them into like a clinical room and chat with them. We try to do a lot of the folks we work with are Indigenous. So we try to meet them outside for walks. Our elder told us about cedar tea, so we can give cedar tea, which helps with anxiety. That's more of a cultural practice that people use. We seem to get a lot more, or if we're smudging, so all of our resource centers, we have, I'll show you what those bundles look like. We have smudging bundles for people, and it's like a calming medicine. So if people want to smudge, they can totally smudge. And the scent really can calm people down. It brings them back to those good times they've had in their community and their culture. Michelle had mentioned the prayer rugs for people, the Muslim folks that need times to pray when they're in any of our centers. And we're always looking at trying to include community voices in any of our planning. So all, like I said before, all that information, I mean, we do have advisory meetings. We do get people to fill out forms, questionnaires, like we have those. And then they tell us they're sick of doing questionnaires. I'm like, that makes a lot of sense. So we get a lot of informal feedback by just a lot of conversation. And that's generally how the Indigenous population works. It's through talk and stories and conversation. So here's our vaccine clinic, one of our vaccine clinics during COVID. So on the left here is a community member and that got their vaccine, and a person that's been working there. And then we were able to hire Aboriginal Fusion. So it's actually a social enterprise of a family that I think it was free food for folks. So if you came for your vaccine, you would get a meal. And people loved it. They absolutely loved it. Okay, another thing that's working so a lot, I'm sure you all know about trauma-informed care. We really work with a lens here of a trauma-informed approach. I do a lot of talks and trainings on it within our clinic here and in other organizations. But really, it's about recognizing that most people accessing our services have experienced trauma. And we know this because actually our knowledge keeper said to me, if you are meeting an Indigenous person in Manitoba, you have to make the assumption, or it's safe to assume, that they are impacted by generational trauma from the residential schools. And we see it to this day, because those residential schools only closed in the 80s, I think, or maybe even 90s. Yeah. So there's people my age and that I've met and that I know. So just taking, recognizing that. And it's also about understanding that trauma can impact individuals holistically, right? So we see through people's behaviors and how their relationships and their physical, just their physical being, how they're really impacted by the residential schools. And I mean, we're still seeing so much of the trickle down effect in the families, which has been really sad. And the resilience is amazing as well. I don't want to just keep saying like it's terrible and it's sad as much as it was. They're an amazing, it's an amazing culture. And they have so much resilience, and they tell us all their stories. Like no one has to tell me their story. So striving as an organization to create an atmosphere of safety, trust, compassion, and collaboration with our clients. And I'll get more into that too, John. So choice and collaboration. You know, trauma-informed care differs from the traditional hierarchical expert approach of kind of like the immobilization and having people kind of sit on their hands and telling them what's wrong with them, especially around mental health and trauma. So instead, it uses a lens of curiosity and partnership and empowerment. So it's about really creating a comfortable, safe space, guiding them through those difficult times with their input. So they know what they need best. We just often need to facilitate that and provide that safety. Ultimately, we want people coming away with an encounter with us, feeling empowered and feeling somewhat supported. So like I said, it's about being really curious and collaborative, you know, asking questions like, what do you need? How can I help you right now? What do you already have in your circle? What do you already know that you can do? What's working for you? So it's really getting them to drive the boat, and we're just kind of facilitating, you know, where that goes. So we're really using a strength-based focus on their skills and the resiliency, like I said, providing that safety and providing opportunities for healing and reconciliation. So what would work for them in reconciliation? I'm not going to get too much into this, but you've heard us talk about elders. I don't know if you know what an elder is. So here, like I said earlier, we hired an elder and a knowledge keeper. So cultural advisors play a central role in Indigenous communities. So they're teachers within their communities and beyond their communities. So to us staff as well. So we have hired an elder, and her name is Ivy. And Ivy is a residential school survivor. She's an older woman who is fantastic. She is amazing. So what an elder does is that they basically advise us in our work here. They advise us all in how to work with the community on a in a better way, to be honest. Ivy she tells a lot. The way she talks to us is a lot of stories. So there's lots of stories. She tells us what she experienced, how we can help folks, how everything has impacted the Indigenous folks today, the trauma that they've endured. So that's part of that truth, and how to work with the community with that special lens of care, really seeing their strength and resilience and honor where they are and where they came from. She will also do some visits with some really high needs folks that we have. So we had a young woman in one of our programs who was quite suicidal, and one of the workers was able to ask for Ivy to come and speak, so she did a house visit, and her and this young woman just really, really connected. So just really kind of talking about her culture and talking about their traditions and smudging and sitting with her was really healing for this young woman. So then we have our knowledge keeper. So the knowledge keeper and the elder work really, really closely together. Generally the elder is an older person who has a lot of knowledge and life experience and spreads those teachings. And the knowledge keeper, of course, is just like what it sounds. It's like keeping that knowledge and passing that through to the community. So our knowledge keeper, when she works with community, she's also a social worker. So she is one of those people that would take people outside for a walk, and tobacco and different medicines are used when they're speaking, or they just pick medicines when it's not 40 below. And we grow a lot of the medicines here right on in the prairies so that they can so here's just a couple pictures. So on the bottom right, that is sweetgrass. So we grow that here, and they have to pick it wild. So we can't grow it and pick it. It's to be wild, and that's something that they would go do as a group. Then they can braid it. People just love to braid the sweetgrass. And at the top there is sage. We can also get sage on our prairies here, and they're usually packed in bundles. And then there's a shell. And usually the feather there is usually an eagle feather, and that is to smudge. It's like a smudging helps with. I have it written down here. It allows people to stop and slow down and become mindful and centered. It allows people to remember and connect with the ground and their creator. So this is something that people love to do a lot, and we allow it. We weren't allowed to do it in a lot of places here in the city, and now that's more incorporated. So on the left, you will see women wearing skirts. So whenever there's a powwow or people are smudging or there's a feast, women will wear skirts. I'm not exactly sure why, but it's there's a reason behind it.
And you'll see the center skirt is actually the symbol for Métis, which is the merging of which is actually French culture and Indigenous culture. So they're completely linked. Okay.
Yeah, just so with our NorWest, with our trauma response team, we've been around for about 8 years now, and we've been created to respond efficiently and effectively to our community, whereas before we kind of didn't really have a response. So when we provide people with psychological first aid and post-traumatic stress management, but also when we look at different cultures we work with, that can look a little bit different. So for instance, when we had, when a woman died by suicide in the park across the street from her community, a couple summers ago, our trauma team responded by going to the home. We brought food and we brought tissues, of course, and smudging. And, you know, we told the story, you know, we gave the family our condolences. And then we were asking them, like, what can we help you with? Is there something we can help you with? And they knew. It was really quite fascinating because they knew what they wanted to do. They didn't need us. They did need us, but they knew what they were going to do. So that evening at sunset, they wanted to do a vigil where the woman had died. So they just needed help with candles, food, art supplies, and those sorts of things. So we were able to bring that with them and then meet with people one-to-one who were having a really, really difficult time. And all the women from the community, it's a housing development. There's like 1,000 people there. A lot of people came out, kids, families, and the women were all wearing skirts and they brought their own hand drums. The men use the big hand drums together and the women have smaller hand drums. And they were singing and praying, and it was really fascinating. So that was just one way that we could help with that.
So merci, miigwech, and thank you. And I think the only thing I wanted to add is, while there's a lot of work we're doing and talking about community, one of the challenges we have as staff here is recognizing our bias, right? Because that can be a challenge when you're trying to cross cultures, and figuring out how do we become aware of that. So we actually have mandated training, what's called MIST, which is cultural awareness training, and then we try to embed processes and policies as we go along, but it is a work in progress. And I know I heard about like the injustices going on right now we're aware of in the US, and just like we're aware of them here in Canada too. And I do think it's a work in progress as we go forward. This presentation was meant to give you an idea of what we're trying to do, but by no means is it exhaustive or is it absolutely perfect. So it's just, like I said, a work in progress. So thank you very much for listening to us.
Thank you.